Thank you so much for that wonderful introduction, Anne, and for your remarks and insight into long COVID and what we need to do to take the next step forward in addressing this. So again, thank you, welcome. I'm going to give really just kind of a highlight snapshot view of long COVID. It's really complex. We're learning more every day. And so my goal is to just kind of review some of the clinical manifestations, the epidemiology, and then discuss some outlines for kind of the clinical approach to managing these patients based on our experience caring for these patients in our multidisciplinary clinic. Next slide, please. So starting with some definitions, what exactly is long COVID? Well, the definitions actually are still evolving. We know that many patients who have COVID infections will continue to have symptoms for weeks, months, or even years after their initial infection. And this is often regardless of how severe their initial infection was. We're still struggling to have a defined terminology. Some of the terms that have been used are long COVID, post-COVID syndrome, post-acute COVID-19 syndrome. Patients are often referred to by the lay public as long haulers, and this is kind of where long COVID came from. Last year, the NIH did announce a terminology of post-acute sequelae of SARS-CoV-2 infection, or PASC, which kind of is a term to, encompass all of these different post-acute phases. Next slide, please. I really like to, think of COVID-19 as a spectrum. And I think this image highlights that really kind of from the acute COVID infection continuing to the post-acute phases. When we talk about long COVID or PASC, we're really referring to patients that are in kind of the right-hand side of this image. So those that are in the chronic post-acute phase. At this point, the infection has ended. There's no longer active viral replication or the ability to isolate the virus from the respiratory tract, but patients may continue to be symptomatic. But again, it's not due to ongoing viral replication. Next slide, please. Long COVID can overlap with many of the other complications of acute COVID-19 illness. And so sometimes it's a little bit hard to tease out what is long COVID versus, what could be attributed to complications from a prolonged hospitalization, for example, or an ICU stay. We know that some of the effects from, hospitalization could include, for example, tracheal stenosis from prolonged intubation, severe weakness, deconditioning, post-intensive care syndrome, other things like PTSD, for example. Next slide, please. So this was a really nice systematic review and meta-analysis that was published in late 2021, where they looked at really all the publications to date on long COVID. So it's over 18,000 publications, and 15 of them met the inclusion criteria for the systematic review. And based on this, the authors were able to estimate the prevalence of 55 long-term effects. They did 21 meta-analyses, and this was almost 50,000 patients included across the full adult age spectrum. The studies had different definitions of long COVID. So some, said symptoms as early as 14 days, up to 110 days were defined as long COVID. So it was a bit of, heterogeneity in terms of the follow-up periods. But they found that 80% of patients still had one or more symptoms at time of follow-up. Next slide, please. And the most common symptoms that they found were fatigue in 58%, headache 44%, attention deficit 27%, hair loss in 25%, and dyspnea in 24%. But you can see that patients reported continuing symptoms in almost, all organ systems of the body and a huge range of symptoms. Next slide, please. And they also included some studies that looked specifically at lab tests and other examinations, and they found that There was abnormal lung imaging in about a quarter of patients, either an abnormal CT or chest X-ray, as well as elevated levels of pro-inflammatory biomarkers. And these would include elevated levels of D-dimer, pro-BNP, C-reactive protein, ferritin, procalcitonin, and IL-6, which indicates ongoing inflammation in these patients who reported continuing symptoms. Next slide, please. So some general themes about long COVID that we've noticed based on our experience with these patients over the last year and a half are that patients tend to present with a constellation of symptoms. Oftentimes, many organ systems are involved simultaneously. Sometimes patients present with just a persistence of their initial COVID symptoms, but sometimes they develop new symptoms that can start weeks or even months after their initial recovery from the acute illness. So they may initially feel better, in their isolation period, and then the long COVID symptoms can start weeks or months later, which can often make it a little bit more challenging to identify that they are in fact due to long COVID. Symptoms often wax and wane. Patients will report having good days and bad days, good weeks and bad weeks, kind of episodes of long COVID symptoms. Diagnostic testing is often normal, and there's often a really strong psychosocial component. And I think it's really hard to tease that out, what is, due to long COVID versus what is due to the stress of being sick, the stress of the pandemic, or underlying mental health issues. We often see what I like to call an unmasking of other conditions. So patients who will present with new or worsening signs and symptoms of conditions like reflux, asthma, or sleep issues. I think it's a little bit unclear whether these are kind of new diagnoses and the infection triggered them to develop, or whether patients were just very polysymptomatic before, but perhaps they've lost their threshold to compensate, and so these conditions become more bothersome to them. Oftentimes, long COVID patients will end up getting diagnosed with other specific conditions, especially asthma, POTS, things like reactive arthritis, as well as some psychiatric diagnoses like depression, anxiety, and PTSD. Next slide, please. Now I'm just going to highlight a couple of the organ-specific kind of manifestations of long COVID that are most commonly seen. So starting with pulmonary, really the pulmonary manifestations are probably the most common post-acute symptoms. A chronic cough is often seen. This can really be multifactorial. It can be due to asthma or reactive airway disease. We are diagnosing a lot of laryngopharyngeal reflux in our patients, so I think it's also important to consider reflux as a cause of chronic cough. PFTs may show a decrease in the diffusion capacity, but usually the other measures are preserved. A chest X-ray and CT chest may show scarring, but are typically normal. And we often see dysfunctional patterns of breathing. So the lungs themselves may not be damaged or injured, but rather the way the lungs move is abnormal. So there is the way that the diaphragm and chest wall moves kind of creates this, instead of kind of, nice expansion of the lungs, patients are more breathing kind of with their ribs. It causes a lot of chest pain and discomfort, and it also causes a sensation of shortness of breath. And in this situation, breathwork exercises can be really useful to retrain the muscles of breathing. I think it's also important to do an assessment about sleep and potentially evaluate patients for undiagnosed sleep apnea, which is commonly found in patients with long COVID. Next slide, please. So touching on the cardiovascular manifestations, what we see is a lot of dysautonomia. So patients who are presenting with tachycardia and orthostasis. Orthostatic vital signs are a really easy way to screen for this in clinic. There's a lot of exercise intolerance and post-exercise fatigue. The physiology can often resemble severe deconditioning. There's, this growing understanding that long COVID can trigger POT syndrome, which can be precipitated again by cardiac deconditioning. It's seen more often in women who are of childbearing age. The orthostatic vital signs can be a good screening test, as well as, a good history. And then tilt table testing would be the more definitive diagnosis for POTS. And there are medications and exercises and kind of lifestyle modifications that are quite successful in managing POTS. Patients may also report chest discomfort and palpitations, which can be unrelated to POTS or orthostatics. EKGs may show tachycardia or PVCs, but are mostly normal, and echoes are almost always normal. Next slide, please. As Anne mentioned, the mental health aspects of long COVID are immense, and we know that many patients, probably the majority of patients with long COVID, will have some sort of psychiatric manifestations. The Lancet Psychiatry published a nice study last year that did a 6-month follow-up of about 250,000 COVID patients, specifically looking at new neuropsychiatric diagnoses. And they found that about 1/3 of the patients had a neuropsychiatric diagnosis. And 12% were new since having COVID. The most common were anxiety and depression, although there were a minority with more serious conditions like stroke and dementia. And they found the highest rates were in those patients who had ICU admissions. So, perhaps this again is kind of an overlap with that post-ICU syndrome, where we know there's a lot of anxiety and depression that comes out of that. Sleep disorders were seen in up to 30% of patients. So again, really important to consider sleep and doing symptom screening for sleep disorders. There was a large burden of pandemic-related stress. And we know that, some patients may experience PTSD-like symptoms related to their acute illness. Next slide, please. Specifically looking at the neurologic aspects of long COVID, the most common symptom reported is brain fog. This can include difficulty concentrating, short-term memory loss, impairments in executive function, and brain fog is really debilitating. And I think, from a societal level, this is one of the symptoms that's really preventing people from going back to work full time, from kind of re-engaging in their daily lives. Many patients will have headaches. This can either be a new headache or a worsening of a pre-existing headache disorder, such as migraines. It's not uncommon to see patients who previously had very kind of intermittent and well-controlled migraines now have daily migraines that don't really seem to respond well to typical migraine treatments. Neuroimaging is almost always normal. There's rarely any evidence of inflammation or infectious lesions or strokes seen on brain MRI. MRIs often will show white matter changes, but these are usually not concerning unless they're severe, and there's really no clear correlation with COVID because we know that white matter changes can be due to things like age, underlying migraine disorders, or vascular disease. And cognitive testing is really important for patients who are reporting brain fog symptoms. The MOCA is a really good screening test that can easily be done by an assistant or somebody in the medical office. And based on that, you can determine if a patient may benefit from further cognitive screening. Next slide, please. So, the role of vaccination in long COVID is something that's received a lot of attention recently. And so I wanted to make sure to briefly mention it today. Having long COVID is not a known contraindication to COVID vaccination. And I have seen many patients who tell me that they've been told not to get vaccinated because they have long COVID. And there's really not a strong reason to recommend that to patients. There have been several studies that suggest that vaccination may actually improve or resolve symptoms in some patients. Although I will note that in all of those studies, there were a small subset of patients that reported worsening or relapsing symptoms. But overall, more patients report an improvement in symptoms compared to a worsening of symptoms, although many report no changes in symptoms overall. And when we look at studies assessing the effectiveness of vaccination before infection, it looks like vaccine may reduce the likelihood of developing long COVID symptoms. So it's, another benefit of vaccination may be that patients would be less likely to develop long COVID, even if they did have a breakthrough infection. Next slide, please. So, the big question is what causes long COVID or PASS? And it's really still unknown. We're getting more and more evidence every day of kind of some different mechanisms, but kind of the underlying pathophysiology and, is really, I think, still largely unknown. We don't have any clear correlations of long COVID with antibody levels or with severity of disease. I think certain symptoms may be more common in people who had more severe illness, but overall development doesn't seem to be tied to hospitalization or severe illness. Some of the potential mechanisms may include virus-specific pathophysiologic changes, so actual damage by the virus during acute infection. There's likely a large perturbation of both the immune responses and inflammatory responses that are triggered by the acute viral infection. And we know this, from other post-acute viral infections. There's some, expected sequelae of post-critical illness in a subset of patients. Some of the other possible factors, that have been proposed include that the viral infection may trigger autoimmunity. There's been some findings of virus neutralizing antibodies cross-reacting with brain tissue, for example, that suggests, involvement of specific autoimmunity in certain organ systems. Long-term viral persistence has also been proposed. To date, we haven't really found any long-term viral persistence in patients with long COVID. But our experience from other viral infections has been that sometimes it takes years to find that the virus is hiding out in immune privileged parts of the body. And there's probably, some fibrosis and other changes in lungs, heart, and other organs, although perhaps the imaging that we're using is not sensitive enough to detect some of these more subtle changes. There's definitely a component of autonomic nervous system dysregulation that may be tied to endothelial dysfunction. And again, the psychological component is often integrated. And so, it's really hard to kind of tease out different mechanisms. Next slide, please. So this is just kind of a really general outline of the approach that we've taken to long COVID workup and management. The workup really should be limited. It should focus initially on ruling out clinically concerning signs and symptoms. So it should be symptom-based. As you can see, there is probably over 200 symptoms that have been reported in long COVID. And so you can't possibly do testing for every possible symptom. You really have to target it at the specific symptoms the patient's having. I will note that normal test results and ruling out other serious conditions can often serve a therapeutic purpose for many patients. We shouldn't just do lots of test results just for that reason, but I think it is important to acknowledge that. Cognitive testing, like the MOCA screen, can help identify true deficits. Physical rehabilitation is a really key component. So this can include pulmonary rehab and or physical therapy. But it's important to take a really slow, stepwise approach to progressing in any physical activities so that it doesn't trigger relapses of symptoms. I would consider, using integrative medicine approaches. We've had a lot of success with using acupuncture to treat pain and fatigue. So, I would keep an open mind, especially if you have integrative medicine facilities or practitioners available in your health systems. It's really important to address mental health issues and sleep disturbances, including, the 5 pillars of health. So mental, physical, emotional, social, and spiritual. In general, we recommend only referring the most medically complex patients to specialty long COVID clinics, just because, you know, these clinics are limited, there may be long wait times, and I really think that primary care providers and community care providers can do a lot of the initial symptom workup and screening. And, you know, we really try to focus on healing rather than therapies. There aren't any targeted long COVID therapies available. And so, you know, we want to offer ways for patients to heal while, you know, we're hoping to eventually get more better therapies in the future. Next slide, please. So I'm just going to wrap up with describing some of the clinical challenges in long COVID. You know, I think it's important to note that not all post-COVID is long COVID. Not all patients presenting with symptoms after a COVID infection truly have long COVID. And in a sense, long COVID is a diagnosis of exclusion after other illnesses have been ruled out. And I think this is especially true for patients who don't have a confirmed COVID diagnosis. They, you know, may have felt that they had a COVID illness, but we don't actually have any documentation for that. You know, and it's important to know that COVID may exacerbate pre-existing conditions, and the patients may not just have been, you know, aware of those previously, or they may not have ever sought care for those conditions previously. You know, as I mentioned, it's really difficult still to understand the underlying pathophysiology and disease processes. And we don't really have any standard diagnostic criteria. We lack clear guidelines for evaluation and treatment. Oftentimes there's lack of uniformity in the approach to long COVID within the same institution. So I do think we need more large prospective studies. A lot of these are underway right now. This will help us better evaluate the natural course of COVID infection, truly define the long COVID syndrome, and identify the best rehab techniques and clinical management strategies. This has, you know, the potential to be a really resource-intense condition. You know, oftentimes for the most complex patients, multidisciplinary care is needed. So it does have a potential to be a huge strain on the health system, with lots of demand for ancillary services and support staff. So I think it's really important that, you know, we plan for the surge of patients and do our best to kind of manage them in the most equitable manner that we can. Next slide, please. So I'll just close with this quotation: healing is a matter of time, but is sometimes also a matter of opportunity. And so really, you know, our goal is to help all long COVID patients heal and to find kind of their own path towards a recovery. Thank you.